This will be a bit longer and it's a bit more complicated. It's the nature of the topic. So, pelvic floor exam, if you really want to think about what do you do, keep in mind there's this acronym PERFECT, and PERFECT makes you look for power, endurance, repetitions, fast contractions, elevation, co-contraction, and timing. PERFECT is the key. So power is essentially our MRC scale. For pelvic floor we call it Oxford, 1 through 5. You know the 1 through 5, it's not much different. Endurance is a little bit different. With endurance, we're going to actually make the person hold a contraction. So you see this lady blowing out, but actually going to pinch that sphincter, the anal sphincter, really tight and hold it. And we're going to see how long they can hold, and we count. The next thing is how many times can they contract that sphincter with your finger inside of it over and over and over again until they fatigue. The next thing is how many fast contractions can they do on instruction. When the pelvic floor contracts, it lifts up. So they should be able to lift their pelvic floor away from your finger instead of this, where you might see it come towards your hand or blowing out, which is completely the wrong movement. So you have to really watch that area as you're doing this exam. The next thing is some people will start clenching their face, or they'll use their hand, or they'll contract their belly. This is co-contraction. This should not happen. You don't need those muscles to make the pelvic floor work, but people had developed wrong habits over years, and they come to you with pelvic floor problems and they have these habits. So you should watch these signs. The next is timing. Can they do it when you spontaneously tell them to contract the pelvic floor without warning? Right? Reflex contraction. So that is roughly the pelvic floor exam. And I promised you a difficult topic, right? So when you do this perfect exam, what you get is this kind of information. Is this a hypoactive pelvic floor? Does it not contract fast enough? Does it contract too fast? Is it painful? Is it painless? Because all this gives you an idea of what you're looking into. The question is perfect really perfect? And the answer is obviously not. It doesn't give you enough information. So the information you gain from doing this perfect, or the Laycock exam, is overall neuromuscular function of the pelvic floor, possible muscles involved, but you need more information to make a diagnosis and a treatment plan. You need to know, are there trigger points? Why are they there? Specific muscles involved so you know how to treat specifically. Kinetic chains. If you attended my last talk, you know this already, myofascial chains. And then the person involved. You would think you don't need to worry about the person because they have a disease, but actually they're part of the problem sometimes. So myofascial trigger points. You guys already know all this stuff. Why are there myofascial trigger points causing symptoms? Because the myofascial trigger points will trap the arteries and veins that run through them along with the nerves. So you can have neuropathic pain in relation to a trigger point because the fascia around them is trapping them. These trigger points don't always have to be clinically active. Whether they're present, they will always be creating problems. So they may not be hurting, but they'll still be creating problems. The question again is, why are they there? So if you want to understand that, you have to understand posture. This is the core to musculoskeletal medicine. Wherever you look in the body, this is the core of it, right? There's 4 basic posture patterns. Kendall's shown us in the 1960s. Learn these things, they will make you unique. But more importantly, ideal posture in the pelvic floor. So you can see the red circle on there, that is ideal posture, where the pelvis is anteronutated ever so slightly. And the balance of tension on the muscles versus the power they can generate is optimal. Now, everything is balanced here, and the pelvic floor is not being deformed. Here, this is a kyphotic lordotic posture. The stereotype is going to be your 50-year-old female who's multiparous and has a really big belly. The entire pelvis tilts all the way forward. And when it does, the back end sticks out a lot, right? Now here, the posterior muscles will be really short and tight. The anterior muscles will be overstretched. This is your typical flat back. It's your typical 50-year-old male. If you look at them from the side, their pants are falling off the back end. There's no tissue holding it in place, right? Again, the posterior muscles are overstretched. The anterior muscles are short and tight. This is sway back. You can find it in both genders. The sway back posture has a retro tilt, but the pelvis is pushed forward also. And again, the same kind of imbalances persist. Now, this is the key to figuring out what's going on with the pelvic floor. To really get into pelvic floor, we have to go into a little bit of OBG. So back in the 1990s, there was this Italian OBGYN named Arturo Pescatori. And Pescatori only treats women, he only treats older women, he only treats them for SUI, stress incontinence. And he figures out that there's these slings in the pelvic floor, and that if he stitches them shut, then everything gets better. Now that's from an OBG perspective. He uses Teflon tape, everything gets better, right? But we can use this to understand the pelvic floor better. That is your pelvic floor. Your pelvic floor is a hammock that all these organs, bladder, uterus, rectum, all sit on. And this pelvic floor pushes up and keeps the abdominal contents inside. It prevents them from leaking out, but it also descends to allow things to actually come out as needed. So when it's not working properly, you have a problem, but it's not one thing, it's actually 3 different zones. So you have our kyphotic lordotic posture, right? Where everything is tilted forward, everything is overstretched in the front but tight in the back. And what does Pescatori find? Pescatori finds that if the front ligaments are overstretched, you'll have stress incontinence. The bladder descends, it stretches the ligaments, makes them have to pass urine all the time. Fecal incontinence can also happen. With the sway back posture, here's the intermediate ligaments that are compromised. Cystocele happens. Abnormal emptying, frequency, urgency, and what you see on the bottom is actually going to be pelvic floor pain. And here with this back ligaments that are overstretched, the typical flat back, rectocele, in a female uterine apical prolapse, abnormal emptying, frequency, urgency, pelvic pain. So to really understand the pelvic floor, you should understand the basic posture first, because that will inform you what's going on. Not every single time, but in general, yes. So we've got Pescatori, we understand the slings, now we have to connect all this together to make sense of this, right? So how do you do that? How does Pescatori's slings link into posture? Well, it links to the pelvic floor, and it links through myofascial chains. Myofascial chains we spoke about last time, they're all over the body, it's muscles that link together and function together for basic daily tasks. So there's a lot of myofascial chains, there's a lot of pelvic floor symptoms. The deeper you go, the more complicated it gets, but you should understand there's a few chains, and we'll name a few to start. So, superficial front line. Superficial front line is the one you see where the arrow is pointing towards it. It's those set of muscles that all fire together in tandem to make particular actions. Now, the superficial front line will link into pubococcygeus, but circle, puborectalis. They link together. So when there's a dysfunction in the superficial front line, you can expect pubococcygeus dysfunction, puborectalis dysfunction, which will manifest as myofascial trigger points in iliopsoas, but also urinary frequency, urgency due to excessive pressure on the pelvic floor, and pelvic pain that's made worse by standing and walking. This is complicated, I know. What I want you to understand is these things link together. So just treating pelvic floor alone is never enough. You have to link it all the way into the entire body. One more example, the deep front line. So you can see the deep front line here. It's a small group of muscles. Deep front line links into levator ani, coccygeus, obturator internus, pelvic fascia. And then the manifestation is pelvic floor tension myalgia or chronic pelvic pain. And you have people who have difficulty with deep breathing or core activation due to diaphragmatic pelvic floor desynchronization. So, myofascial trigger points. You know what they are. We can find them all over the muscles, all over the body. We can find them in the pelvic floor also. And we know what they do to the fascia, we know what they do to the nerves and the blood vessels in that region, which is why we have those clinical features. When trigger points become present, either they're actively irritating the body, irritating the nerves around them and causing problems, or they're just cold and not letting things move the way they should. This creates noxious stimulus that becomes a vicious cycle that drives all these problems that eventually manifest as a pelvic floor dysfunction. Mind you, why are they there? Because the core is weak. So now you've seen a pelvic floor exam. Quite complicated, right? And we haven't even touched on all the myofascial chains. But the exam outcomes now, organic. You do this exam, you find something objective, you know what to treat, you know how to move forward. That's an easy case. Non-organic. Every finding is negative, but the person is still complaining. What do you do? More common, mixed. Not so easy, not so hard. You find stuff that doesn't explain everything that they're talking about. Many of these people that come with pelvic floor pain will have a back pain or a neck pain at the same time, when one that started probably 5 or 10 years before that. Then they complain of genital pain, difficulty passing urine, constipation. So if we find objective evidence of a problem, we can use guidelines to treat. There's guidelines for everything now, right? If we can't, we like to call it a functional disorder, and then we make it someone else's problem. But whether we believe that that person has a condition or not, for that person, suffering is reality. And if you don't take them seriously, you're not doing your job. So, it's going to get worse now. To really understand pelvic floor, you have to shift your perspective. And by shifting your perspective, I mean this. The pelvic floor is often a victim, not the aggressor or the problem. I think you understand if you understood the posture part. What we do in medicine is we tend to divide objective from subjective. And then we think we're going to succeed. We throw out half of it and say, we got what we want, we'll treat that, let's see what happens. This is wrong. Every disease, or dis-ease, is a mix of both these subjective and objective things. Some of these people actually create their own problems. So if you don't identify that, you can treat to no end, but they won't get better. I think if you walk out with any message here, the pelvic floor exam and rehabilitation is not Kegel exercise. That's the worst thing you can do. Your colleagues only know that because that's all they learn in MBBS, but there's so much more, as you just saw so far, and you'll see more. Kegel can actually make things worse. Most referrers don't know this. So once the diagnostics and therapeutics of a problem are over, you're left to treat with the person who has that problem. And this is what makes pelvic floor so hard to deal with. The first step to treating the person who has the problem is to figure out no two cases are identical, even if the clinical features and severity are the same. The path they took to end up in front of you is relevant to treatment, their entire life history. It sounds so boring, complicated, confusing, nonsense, but it's part of why they have this issue. And you need to get a grip on these things that are subjective if you really want to have success. So how do we analyze the subjective? The subjective is both an experience, like you guys hearing my funny accent, and how you handle that. Now, in the body, that manifests in two particular ways. Whoa, sorry, that animation went too fast. So experience will be personal experiences or lifestyle factors, the way people do what they do. The other part is how experience is handled in the body. So if I point at this guy, he might laugh, he might feel threatened, right? It's a unique response that everybody has, right? But how they process what they've experienced determines how their body responds and how they develop problems or not. And in the body, this manifests as the inflammation reflex arc. So we're going to talk about inflammation reflex arc, or the autonomic nervous system, because it's something most doctors don't understand, and if you do this, you can do what no one else can do. So we have this thing called inflammation reflex arc. If I bump my hand on this table, it's going to swell up, they'll get some redness, erythema, and it'll go away, right? That's good. The damage gets healed up, right? You need to have inflammation in your body to make it grow, to make it heal, to make it get stronger, make it get better. The inflammation reflex arc has a control center in the medulla. It has an efferent limb, which is your autonomic nervous system. It works through the immune system cells that will release cytokines, and then the glomus or the vagus will actually go back and inform the control center, hey, the job is done. So if it was a closed system that we could control, everything would be fine, but that's not the case. There's exogenous ligands like HMGB1, which is a nuclear protein. When cells die, this activates inflammation. That's okay, you want that. You want dead tissue to be healed. Heat shock proteins, which come out with negative experiences. If I go and shout at someone, they might have a negative response, and heat shock proteins can go into circulation. They can trigger this inflammation reflex arc. Uric acid, interleukin-1 alpha, annexins, nucleolin, all these endogenous ligands can activate it, but it's not just endogenous ligands, it's also exogenous ligands, lipopolysaccharide, which you find in the cell wall of gram-negative bacteria. Lipoteichoic acid, again the same thing. CpG-containing DNA, dsRNA, hemazoin, flagellin, these are typically bacterial products. You want the body to fight these things because if you don't, your sepsis will kill you. The real issue we have is partly our lifestyle right now. The way we respond to environmental stimuli, being stuck in a chair for hour after hour, day after day, can load the body and make inflammation through trigger points, right? Memory stored in the amygdala, that we don't like the way someone looks at us and talks to us, that triggers this kind of a response. Bad posture, pro-inflammatory food. A lot of food comes with preservatives. They're meant to keep the product on the shelf. It's not fresh or healthy. It activates inflammation in the GI system. Myofascial trigger points, age protein. So all these different things can actually activate this immune inflammation reflex arc that drives up the pain. And like I said, the pain will start in the neck or the back, and over time it progresses to the pelvic floor. Then it becomes these kind of things that no one knows how to treat. But many of these things are the way a person responds to life. So if you don't know that, you can't help them. So to summarize all that into one little box, we're going to say maladaptive stress is a response to stress. Stress is good. Stress makes us stronger. Stress makes us better. Residency is a stress. You get a degree at the end, right? If you handle it the wrong way, you'll never succeed. If you handle it the right way, you can really do well and do good for other people. If we don't have the proper response to stress, take it in stride and move forward and grow with it, then what we end up having is a vicious cycle that drives and perpetrates pain and makes people suffer horribly. And this is what most people with pelvic floor functions actually have. Diseases don't suddenly emerge. Nobody wakes up with a pelvic floor dysfunction one day. And they know they have a problem because they were at some point in a state of relative health where they didn't have these issues. So when you see a person who has that, they started with health, they go to work, their boss shouts at them, okay? They have a stress response. They don't go into a full-blown disease, they don't have a headache, they don't have back pain after that, but they're not feeling so great. They bounce back and go back to a healthy state and they can function again. But then the stress comes again. Boss shouts at them again. That's what bosses are good for, right? So boss shouts again. This time they have a bigger response. And now they're getting more closer to a disease state. It happens again. They know they shouldn't react. They don't react as much. But when this happens over and over again, you find people who they start shifting towards this pre-disease state, and then eventually they get worse. So pre-disease maladaptive processes, not handling stress properly, become so bad that disease finally emerges. And the latency period between these events decreases until the baseline starts to really, really shift. And then it shifts so far that people are always unwell. They're always at the point of no return. And disease becomes autonomous. And that's literally what you see as a lot of NCD, non-communicable disease, hypertension, diabetes, all these different things eventually be driven by these kind of poor choices and poor responses. So, having said all that, now we can talk about the etiology of pelvic floor dysfunction. How does pelvic floor dysfunction begin? The most common things will be myofascial pain, neck and back, life stressors. People who have depression can be prone to it. Post-surgical adhesions, infections, cancers, endometriosis, trauma, inflammatory bowel syndrome, irritable bowel syndrome, all these different things can drive up this kind of a condition. The most common are in red, but this is how it begins. Where does it begin? It begins with history of life, what that person has experienced to the point they come to you for help. There's events in a person's life that they internalize and they store as memory to protect themselves. And that would be where the brain starts controlling the body and driving up these problems. We'll look into this in a bit, but central to peripheral modulation is one. There's another type of person who's had a relatively healthy life. They've never really had much problems. Life has been good for them, but they have excessive exposure to stressors at focal areas in the body. What we see in a lot of children now is neck pain and back pain. They're bent over on a screen, right? So lousy posture, too much blue light through the eyes, brain can't relax, right? Excessive stimulation. So either they have a past trauma or they're being excessively stimulated, but this is what drives these conditions. So this is peripheral to central. But the issue will be in the tissue, and that tissue is the fascia. And the fascia is the largest organ in the body, not the skin actually, the fascia. And the fascia has so many receptors in it. And all those receptors feed into the dorsal root ganglion, into the dorsal horn, and then they go into the brain, into the hypothalamus, and they'll modulate behavior. So if we're not maintaining good posture, like most of us in this hall right now, these things can actually start manifesting as problems later on. Again, it's not just that the sensors in the fascia go and jam things up. There's other things that are really trying to get into the brain and give signals. Muscles, tendons, organs, blood vessels, skeletal muscle, all the other receptors in the skin. They're all trying to feed in at the same time. And if the dorsal root is being bombarded by signals from the fascia, things don't go through. So what ends up happening is flow into the central nervous system should be a two-way thing where there's an outflow and an inflow that's relatively equal and the body can modulate itself. But if it's being jammed by one, then sometimes organs don't work well. And there's a really good study from probably the last decade that shows that if you treat myofascial trigger points here in the interscapular region, hyperacidity goes away. Right? So why? Because it's on the same dermatome, the same myotome. Dysfunction in the myotome will make dysfunction in the organ that correlates to that same root. This is what we see as people who cannot pass urine properly, people who cannot defecate properly, people who have pain with erections, pain with receiving a penetration, things like that. This is why this happens. Diseases slowly evolve until they become what we clinically see. So it's not putting a name on something and treating that, it's understanding where it came from so you can take it to the root and solve it. Again, you can have the peripheral nervous system getting so jammed up that the dorsal root ganglion will start to grow new sprouts around those fibers that are firing the most, which are coming from the fascia. And what you get is central sensitization. I think you all know this. So this is where you can have the peripheral modulating the central. Trigger points from out here and now start making the brain more and more anxious. You say hello and that person is terrified, right? Or you can have a person who's had past trauma or something that's overstimulated. You say hello. They're terrified because it's the brain that's overactive, overreacting to simple things that are being offered to it and doesn't know what to do with it. This is what makes pelvic floor problems emerge. We're back to pescatory. So someone from the PMR background realized pescatory knows what's going on. And they took pescatory's model and it says Goshen down there. So Goshen said, hey, what if we apply this model to pelvic floor pain? Right? So what you see at the top is pescatory's iceberg here is the chronic pelvic pain apical prolapse. right? And that's what we see in our clinics a lot of. Out of this cohort of 201 people, 198 had this kind of an issue. But what Goshen was getting at is there's actually a lot of other small symptoms: your residual urine, nocturia, obstructed defecation, stress incontinence frequency, bladder emptying issues, urgent incontinence. All those things, if you don't address them, you won't get the full picture of what you're treating. You won't understand which viscera, which nerves, what areas are in dysfunction, and why. So they did this correlate with Pescatore's model and turned into a pelvic floor model and find quite a good correlation. The end result is you get 3 phenotypes of people who come with pelvic floor dysfunction. The first is the organic. You do your exam, you find objective things that you can actually treat. The next is mixed. The picture makes some sense, but there's some things that don't really make sense. They shouldn't be so bad, but they're much worse. Or the non-organic, where the exam is relatively straightforward and it's perfectly normal, but they're complaining of symptoms left and right. So, we have our 3 phenotypes. We want to know what happens to all these people. I'm not going to talk on treatment. This has gone quite on a long ways. If you want the full talk, it's online on my YouTube channel. But we have our 3 phenotypes, and here are some of the common treatments you can do. So with mixed and organic, you can inject their pelvic floor, you can inject it on their nerves, you can get in the autonomic ganglia with needles. It's okay, you can help them. You can do EMG biofeedback, exercise, lifestyle modifications are all really big here. If it's non-organic, I'd look into more neural therapy, autonomic nervous system modulation. But at the end of the day, you get particular outcomes based on phenotype. So the organic phenotype has really a lot of objective findings. Mixed is a mix of both, and non-organic is mostly subjective findings, where the exams are normal, but the patient's still complaining. Now, what outcomes do we get? Well, you can have 3 possible outcomes. Whatever you do works. We're all happy if that happens, right? The other thing is whatever you do works until it doesn't work. That's a real problem, because they're going to be happy for a while. They'll come back to you complaining again. Or they just keep getting worse. And how do these things play out now? Now we know the outcome. If you don't treat them properly, 50% of these people will have anxiety, 25% will have depression from these kind of issues. So who ends up where? Now, the objective kind, whatever you do will work. With the mixed kind, whatever you do works until it doesn't really work, because you've missed part of the picture. There'll be something in their lifestyle or their past that's driving this. Sometimes they get worse, and that might be actually the way you've approached the entire issue. With the non-organic, they might get better till they don't. They have an actual non-organic issue, which is going to be something psychiatric usually. The other things, they keep getting worse. So the easy cases you can send to a therapist, there's no problem. Therapists can put their finger there and make them do a Kegel and everything is okay. That works out. But what we really want to do is take care of these people so they don't end up worse. Because if they're worse, their family suffers and society suffers in general. That's not our job, right? We're to make people better, right? So why do these people not get better? Tangible factors, like we've seen with the physical exam, the myofascial chains, all of that stuff. There's also a lot of intangible factors that you can't really put a p-value on, make a paper out of, and make yourself glorious with publications. And those are things like lifestyle factors. Do they get enough sleep? Are they getting adequate hydration? Do they get enough physical activity? Are they managing their stress well? This takes a different skill set, but it's very much a physiatrist skill set. There's also non-modifiable factors that you just can't change. Gender. Females' brains are much more sensitive than the male brain. The way they perceive things, the way they respond to things, all is very different from a male brain. Sex hormones. Testosterone will increase the resting muscle tone and the sheath. So again, people are more prone to getting trigger points of a much tighter, much more stiff. Age. As the body gets older, muscle gets replaced by fat. The muscle becomes weaker, becomes less flexible, and again, it gets more and more dehydrated, right? And then personality cluster. So, do they belong in the ABC personality cluster? That you'll have to actually look into. But this determines how they're going to interpret life events. I think when I wrap up here with the next few slides, I want you to understand really something simple. With a lot of non-communicable disease, we're not actually going and labeling a disease and treating a disease and succeeding. What we're doing is removing enough of the factors so that a person can bounce back and be who they are. This is resilience, their ability to handle themselves, right? And when you remove all these confounding factors, they can shine through and be who they are. They'll be happy and they'll be okay, even if they're not perfect. The goal of all healthcare, especially with non-communicable disease then, is actually to help a person work with this. We have to help a person bounce back and keep moving forward. When you treat disease, ignoring the person and only treat the disease, you're overlooking this thing. When you treat the people who have these things, it's unavoidable that you end up helping them with their resilience and helping them get better. So the path so far, if you're in my last talk, we'll do some funny stuff at the end. The path so far with healthcare is, once there was this noble profession called healthcare and medicine, but it's been reshaped into this modern healthcare industry, right? And patients are clients, treatments are products, physicians are service providers. And the art of medicine is slowly being overshadowed by economics. Now, this is all happening because people are stuck on a disease rather than not the person with the disease. So, what I want you to walk out with, if all that was too confusing, is your patients will teach you. Do the best you can for them every single day. If they succeed, great. If they don't, go back and learn. Go back from the basics again and keep on trying to figure out what's going on until you can help them. But whether you want to learn or not, you're in healthcare, you'll have to keep on learning, and your patients are going to be the ones who teach you. That's all.
Yeah, one question is, when you meant exercises, are you meaning exercises only for the pelvic floor muscles or for the whole myofascial plane that you were talking about?
So it goes both ways. Many times when people are referred for pelvic floor, my colleagues tell them, go to Ravi, get some exercise. So they come biased ready to get something. If the pelvic floor exam looks normal, we'll focus on their posture, their entire core. If the pelvic floor looks abnormal, we'll start with that. So it can go both ways. I think one of the best exercises actually is all on getting them to breathe properly. Most people don't know how to do that properly, and it overloads the pelvic floor.
And about the role of behavioral therapy, CBT, and
I have a bias. I work in Kerala in a private hospital, and people hate that. If you tell them psychiatry, psychology, they think you're insulting them, or it's going to give their family a bad name. So definitely it has a role. Definitely I sneak some of it into my actual work when I deal with them. There's simple ways to get them to breathe properly that calms the nervous system down. There's ways to help them with their issues without making it a psychologist issue. Some paramedics can be very good, some aren't, and you don't know who you're going to get sometimes. So as long as you have the skills to handle it, you can do a good amount on your own.
Do you add any medications for that, like
I usually end up
like
removing
we
them.
use for fibromyalgia, like pregabalin or duloxetine?
So my colleagues do all that for me, and they love baclofen and they love pregabalin, and my colleagues will always load the patient up with pills before they send to me. So all that's left will be injections, counseling, or these kind of exercises.
Thank you.
Thanks for the questions. I wasn't expecting any.